Hi, my name is Clare and I'm the mother of 3 teenagers with FASD.
And I'm Jessica, a PhD student researching educational interventions for children with FASD.
And together we are the hosts of a Spotlight on FASD, the UK's first podcast dedicated to shining a spotlight on fetal alcohol spectrum disorders.
FASD is a condition caused by prenatal alcohol exposure that affects hundreds of thousands of children across the UK.
And we're here to bring these conversations out of the shadows and make sure that no one living with FASD feels alone.
Hi and welcome to episode 6, part 2 of Spotlight on FASD. This week's episode is the second half of our brilliant interview with Dr Raja Mukherjee, where he talks about why now is the time to change the narrative around FASD. What are the most common misconceptions that you find clinicians still hold around FASD?
Well, the biggest one is that you can only diagnose it with the face. And that's the biggest single one.
We still see that on all the forums online. Every single day, you will have people who have evidence that alcohol has been consumed. They've got it's clear as day that that's what the diagnosis is, and clinicians will not diagnose because there is a lack of facial features.
What I ask the people who tell me that is when was your clinician trained?
Mm-hmm.
Because a lot of the pre-2000 narrative was around it's all about the facial features. And if you came from that era where that was what you were told, that is what they know. Mm-hmm. How you diagnose, and what happens with most clinicians is that they train in their area broadly and then they specialize like me. Now I've forgotten more than I've ever know now, if you see what I mean, because ask me about diabetes, forget it, I don't know anything about it anymore, but I used to when I passed my medical school exams, clearly, because I had to then. Now take me outside of the neurodevelopmental world, I'm rubbish, but this bit I know really well because it's my focused area, it's my specialism. And that's what happens, is that you get very focused on your little bit and you forget about everything else.
Mm-hmm.
And that's a problem, is if you've learned that the face and you've been told that this is what it's all about, that's what you stick to. And that is the narrative we need to try and change as well, is that we need to show to people, enough people coming through training now, that actually, do you know what? It's not about that. There are things we can do. I was presenting at a national pediatric conference this morning, and just by showing the way that you can do these other bits, and that actually the brain is important, we can recognize similarities and difference, and we can start to tease apart these things. So one of my areas of interest has been around delineating prenatal and postnatal effects. So what is the factors that happen to the brain in utero, and what does postnatal life cause, because that has an impact on attachment and all the other bits and pieces. And attachment in this field is such a big thing, and attachment is something we all do. It's a safety thing that we do to protect ourselves, and we go through that phase of going from just needing our nappies changed and eating and sleeping and pooing, through to identifying anybody, as long as we get our needs met, through to individual and multiple attachments. And that's a standard process that we all do, and you can see scans of people's brains improving and rewiring as a result of this stuff. The problem that you've got is, if you have something that's neurologically already damaged, how does that influence that normal presentation? Because most of the research is done on typically developing individuals, and so you then have to go back and say, well, actually, what's influencing? Because what happens is parents are blamed. It's your fault for being a bad parent. And that was part of our PhD as well, is that we did a series of stuff on parents and carers, and that came out, and there's several people now replicated that a decade later, and it hasn't changed. Parents are still blamed for being bad parents because it's your fault your kids are doing this, not actually that they've got a neurological deficit which explains it. So we've been trying to tease that apart, and we've started to do that in terms of showing actually the brain related stuff is what causes the experience of the world, and that is the factors that are hardwired and doesn't change. So you may well have an attachment issue irrespective of your parenting. You can improve it by not having the psychological overlays, by making the quality of life better, by understanding them, but you're not going to change some of those fundamental wiring. But the secondary disabilities, that psychological distress of all the other bits that go with it, that does come from some of this other stuff. And that is then a challenge, but only by careful research, pulling that apart, Jess, you're a PhD student, you know what this is like. That's what we do, is that we try and pull this stuff apart and get the evidence, and so that places like NICE can then do that, because until then people are still going to focus on faces and little squiggly bits on your hand. When has a squiggly bit on your hand ever got you into prison? Let's face it, it doesn't, does it? It's what's going on in your head. It's the bad choices you make because you're impulsive and you don't think about consequence. That's what gets you into trouble. When you're over aroused and you don't know how to escalate it, and you don't have the sensory inputs to recognize when things are going wrong, and to say, do you know what, I need a bit of space here. That's self-reflection, because you don't have the language to say, this is what's going on. That's what we need to change in order to allow people to behave it. But I can't do that nationally on my own. It needs local services to come and implement some of this stuff. And that's a challenge, because that's the second big thing, is that there isn't a characteristic phenotype. There is. We know what it looks like, but the problem that you've got is other things look the same. And so you have to spend a lot of time ruling out these other bits and pieces. Now, most common reasons people have neurodevelopmental presentations are genetic. But you also know different genetic syndromes lead to different outcomes. And so there are things which people present which I gurr about a little bit, because it doesn't, to me, knowing what I know, sometimes the comparisons don't make sense. And so autism and ADHD are outcomes of brain pathology. And so you will see ADHD and ASD in people who've got FASD, because if you damage the right pathways, you're going to get this. And alcohol causes damage front to back, and if you damage it enough, you're going to get these outcomes. So what you should be comparing it to is something like Down syndrome or Fragile X or Cornelia Lange, which are common genetic syndromes that you will see. And actually that's quite a useful one, because I often then go back to people and say, and this is one of the other misconceptions, saying there's no point. So I ask them, would you refuse, and I use the word refuse because that's what you're talking about, would you refuse to diagnose somebody with Down syndrome? Never met anybody who said yes.
No.
Why is that? And you say, well, they've got the phenotype, they can have heart problems, and they can get dementia. Okay, fine, that's fine. So why doesn't any of that apply to FASD? Because it does. And so the reason they don't do it is because it's hard. Not because it's any less relevant, it's because it's difficult, and because they don't know how to do it necessarily, and it's a lack of confidence. But the importance of it and the so what of it is exactly the same as if you go. So if they're willing to diagnose Down syndrome, or something that's easy because you can see it and it's obvious, then the importance is just the same.
Roger, do you think that the difficulty sometimes as well, do you think that sometimes a clinician might find it difficult to, or uncomfortable to have that conversation with someone because of everything we've talked about, of this blame and shame society? Do you sometimes think they would shy away and rather go down the road of it? Because I think there's so many children misdiagnosed with ADHD and autism and no FASD because it's a bit more comfortable.
So I wouldn't use the term misdiagnosed, to be fair. I think it's a comorbidity as an outcome, but you don't understand it in its context. And so the people with autism will have a broad range of presentations within that context, and FASD gives you an indication straight away what that style is going to be. And the same with ADHD, it gives you different subtype of presentations. So it's not that it's a misdiagnosis, it's an appropriate comorbid, but they miss what's behind it. And sometimes that what's behind it gives you further information in terms of that. For example, that's why people spend so much time looking at Down syndrome with dementia. And there's a big push for that because it's a different type of dementia. And it then understands how you may treat it differently. That's the whole point. And so, yeah, you're right, is that then people don't do it because there's a stigma. But there's a piece of research a master's student of mine did that actually looked at birth mums' experiences. Now, it was interesting who took part, because it was all mums who had been through this and had come out the other end and had gone through a grief process. And I think there's a grief process that people have to go through, both birth mums and adoptive parents, because of what is the perfect child. And for birth mums, it's doubly hard because they also have to go through the guilt of I've caused this. But what you need to do is not ignore it, is you need to support them through the grief. People need to be allowed to grieve. It's a natural process. People get stuck in this position because they don't support them with grief. Grief is normal. It is something we should expect, and we need to help you with it. There's a lovely. I'm quite visual. I like visual things. You'd love this, Jeff. But in terms of what it was, because is that there was a diagram that I saw, is that your grief and your life and you're around it, and what happens is every so often that life then expands and other things come around, but when it comes back to that, it contracts back to that grief. So you never forget the grief and it doesn't go away, but other things can develop. And what you need to do is to help people to develop more. And so the grief isn't ignored. It's not something that goes away, but you learn to live with it. You learn to move on, and then you can make a difference. And I'm going to mention Pip, because Pip was an amazing person, because she was so much a driver for change in this country. And she would kick my ass when I needed it kicked, and she was good like that. Pip and I had a really good relationship in terms of love hate, probably, because she would kick my butt and I would give her grief at times.
I'm going to jump in here really quickly. Raja is referring to Pip Williams, who was the founder of the UK and EU Birth Mothers Network. Pip sadly passed away in February of 2019, but she was such a presence in the FASD world. She was so passionate, so fiercely passionate about the work that she did, and she did not hesitate to speak up where needed and where she felt that her voice would be heard. She certainly wasn't afraid of all the professionals with all the letters before and after their names. She was a wonderful, wonderful woman who did amazing things. And I have no doubt that if she felt Raja needed a kick, she would have been there to do that.
We respected each other a lot because of the fact that we both knew we were moving the same direction for this thing. And she had to go through that same thing, and allowing her to do that made her into such a potent force for good. And to ignore it is to diminish it, in my opinion, because it's saying it doesn't matter, but it does matter, and we should help people. And so there are sympathetic ways to ask these questions. You don't have to go, did you drink? Did you cause damage to your kid? Come on, tell me. You don't have to do it like that. There are ways of doing this which can be sympathetic. It can be done in a way which is helpful to people, but don't ignore it and actually help people, because actually we don't do it in terms of being pejorative. What we try and do is to look at it in terms of a context of developmental history. So one of the ways of approaching, which I really liked and I published on, is to say, actually, why do you say, are you teetotal? Most people will say no. Okay, well, what do you normally drink then? What's your routine alcohol consumption on a normal week? Okay, so you go through that and they say, when you were pregnant, were you drinking like that before you became pregnant, or had you stopped in anticipation of pregnancy? No, I'd carried on because most pregnancies I think, okay, fine. Well, okay, well, if we're doing that then, so were you drinking the same kind of pattern as you did routinely beforehand? So, oh no, I'd stopped them because we were trying, or oh no, I'd carried on, and I didn't realize until then. So when did you actually realize you were pregnant? Okay, at that point, did you change your drinking pattern, or did you carry on as you were before? And they'll go, no, I changed it a lot. And say, okay, so did they change it absolutely and stop for the whole pregnancy, not have it anymore? Or was it something that you had the occasional drink, like some birthdays or parties and other stuff like that? So, oh, I might have had the occasional. Oh, no, I stopped all the way through. Okay, when did you start drinking again? And then that people do, and that's then just part of a normal conversation. It's not trying to do it. And then you say, what about smoking? What about medication? I always start with medication. Medication, nobody cares talking about because they didn't prescribe it, so they're all happy to talk about medication, and you use it as part of a standard history. And there are ways of doing this, but we don't teach them what to do, and that is the challenge of it, is that a lot of this is about educating the people and the professionals to do it better. And whilst I've spent years practicing and getting it right, and I didn't get it right to start with. Nobody does. Anybody who tells you it straight off. I've made mistakes. I look back at things I've said and done 18 years ago, and I wouldn't do it now. I feel like I know what I'm talking about now. I didn't then. I was put into a position where I had to be the spokesperson for this. And it took me 10 years to keep saying to people, I'm not a leader in this. I don't want to be a leader in this. To actually acknowledge that whether you like it or not, you're the only one leap around there, that you've got to do it. And so you have to step up and just do it. And that's one of the other things I like now, is that there's other people stepping up and doing it. It's not just me. And so it feels like we're in this together now. Whereas when I started, there was nobody around. Moira was doing her bit, and she was really great and helped me on the way. But it did take a lot of stuff, especially in the neurodevelopmental field that I was, with a lot of powerful people who were cynics, who some of them are still cynical, who we've had to challenge. And the other thing that I'd say is we shouldn't shy away from the cynics. We need to challenge them. We need to bring them in, and we need to persuade them through power of research, evidence, and argument, not just because we think it's correct, because they're not going to accept that, because they know enough about what the other truth is to do that. So actually doing the research is what changes it, because unless you publish, unless you actually have the evidence, your opinion makes no difference. It is what the evidence shows that matters, and that is where we have to get to. So doing the research is really important. You have to publish on it. There's so many clinicians out there who may think they know what they're doing, but unless they publish the data, nobody else knows. And so that is, I think, one of the big differences that I've made is I just published on it. I published what we found, and we were able to write it up. And that also then helps other people get into the area and encourages them. So now we have a whole network of people who are researching this, and that's really good.
Yeah.
I don't think that's the question you asked me either. I keep going off at tangents, don't I?
You did answer it, and then we'll just expand. But that's what we want to do. That's what we're here for.
Definitely. I feel like we've already covered the next question, which we wanted to talk about the benefits of early diagnosis, and I think we have touched on that. But do you have anything else to say around that? Because
but I think the sooner you can diagnose it is the better it is. Because you change people's quality of life, understanding, putting in place. But actually, diagnosis. Okay, let me do it this way. People think diagnosis is the end point. It's not. It's the start. And that's the thing, is that you have to understand the diagnosis alone without understanding what else is going on and how to support it is a waste of time. It's a piece of paper. Now, we give you a big piece of paper with lots of pages in it, with about 50 pages in it, if not more, and you can wave that around. It can make good kindling, if nothing else. But the point being, it's not helpful unless you get the support. And that's what it's there for. It is designed to be able to give to people to get you the support and that you need. And that's what we need to think about, because if you get that early diagnosis with the support, that's when the trajectory changes. That's when you get the scaffolding put around people. That's when you protect the people from their own vulnerabilities and understand it, and actually make sure that their self-esteem is maintained so they don't end up depressed and in psychiatric services. That people understand that actually when bad decisions are made, it's because they've got a neurological deficit, not because they intended to kick off and do something. And those are the kind of things that you need to put in play in order to change that direction. And the sooner you can do that, the better. But, and this is a big but, it doesn't always present till later. And so you don't lose sight of those people who need follow-up, and it may present later on, because it's when the gap gets bigger. And the more milder your symptoms, the later you will present. And that's something to bear in mind with all this group.
Thank you. I think as well that's making me reflect a little bit on my own personal life with my children. And, I think I have taught myself so much. I've just devoured information over the years. And because I've had nobody around me who knew anything about it, all of the services that I was dealing with. But even still, it does me such good to kind of ground me and listen to you, the week that I have had and the things that have happened. And I'm so good at reminding other people in my children's lives that, this is what's going on. This is brain damage. This is why this has just happened. That sometimes I need to remind myself it. So that listening to you there is making me think, take a little step back from
So your son, talking to him before, he's over aroused at the moment. That's very obvious. Just having that little chat before, his arousal levels are very high. I talk about arousal all the time because it's about understanding it, and it's identifying what that arousal looks at different stages to intervene early. So I talk about a 4-point scale for us, with 1 and 2 being functioning well, mild agitation, and you should live within that for most of the time. If you can stay within that for 95% of the time, they'll function. I get mildly agitated. My wife tells me all the time you're mildly agitated and to calm down, but still. And it's one of those where actually that what you want to do is to live within those, because they can cope with that. It's manageable. But when things happen and it goes up to level 3 and 4, which is moderate and severe, that's where you need to understand and recognize it early and bring it back at that level 3 to a level 2 or a 1, so you never have to escalate to that 4 where they're kicking off and banging off. But because they can't tell you and because they can't understand it, then it's going to be something that you need to work at. And that's the problem, is that when you're living it, you forget because you're in it. You know, it's easy. I'll give you the example. I know that that I shouldn't have. When my youngest was young, he developed RSV, and so he was in hospital with a respiratory syncytial virus. He then, I think, developed psychological trauma to his room because he remembered it. And so if he woke up and there was nobody in his room, he'd start screaming. This is about 6 months old. Little bugger, sort of 2 hours later, still going, if not 3 or 4 hours. And so you're up and down, never falling asleep. But if he woke up and saw you there, straight back to sleep. Now, they tell you shouldn't have a mattress on the floor in the room with them because it reinforces it. I was doing therapy sessions the day after and falling asleep in the therapy sessions because I'd not slept all night. And so you didn't have any choice. And so when you're living it, you know, it's a hell of a lot harder than professionals tell you, you know, and it's all very well for somebody like me to sit there and say, you must do this. But actually, the reality is that you've got to live it. And sometimes what you need to do is take a step back and do that reflection, because what we're telling you is correct. And what we're telling you, you know it, and really, but actually it's not easy to live it when it's at its peak. And if it's going on all the time, it's tiring. And we need to acknowledge that as professionals. And I don't think everybody does, because it is tough. But the flip side of it is, if you talk to people who do take that step back and reflect and say, actually, do you know what, it is this, they actually do a lot better because they don't blame themselves. They don't give themselves the same kick as saying, I must be a terrible parent as well. You realize, yes, it's tough, but, and that but makes a big difference to your quality of life as parents. Having a partner as well sometimes to share it with is useful, you know, because that's the other thing that we try and encourage parents to do, is to be a pair and to be together, because that strength in that relationship sometimes can help as well. And it's not always happens, and people can do it on their own. But I think even if it's somebody like, if, for example, if it's a single parent, then have a parent to do it with, but having somebody else who's a supporter to help you reflect at those times can make a big difference.
Oh, definitely. You definitely need, even if it isn't a physical person there, you definitely need to have someone to, it takes a lot of the fear away, because it's scary dealing with a lot of the things. And sometimes I think it's useful, as I've been listening to you, it has made me reflect on my week. And it's also really important to always remember that a lot of the time, we are in level 1 and 2, and I have got probably 1,000 techniques an hour going on that I don't even realize. I don't think I could write down in a day all of the interventions that I put into place, because it is instinctive now, and I know exactly what needs to do. The tone of voice, the look on my face, the body language, the words that I use all of the time, the temperature, the noise levels, everything. And so, but when you're in the thick of it, it feels like that's all there is happening. But actually, when you just take a step back and look over the top, you think, no, you know, we're in this dip, and we are going to get back out. And we always do get back out. It's just as they get older, the risks are bigger, and it's the understanding around you. But I've had to deal with the police this week, which is always a huge fear of FASD families, and they've been fantastic. Absolutely amazing with us.
But again, if the police understand there's a neurological factor that's involved in it, and they lack capacity during those times, then they'll be more sympathetic and helpful. They're there to prevent harm, but they're also sympathetic when they need to be, and so they can be supportive too. But it's that lack of understanding, because if you didn't know it was FASD and it was just your son's kicking off and bashing into place to bits, he'd be in prison. And that's the difference.
I found myself in a situation in the middle of the night where I'm speaking to police, and I'm not that I'm correcting them, but I'm kind of delivering training. But thankfully, they're very receptive, and also he chooses he didn't choose to do that. What happened? This has happened to his brain, so he's incapable. So is he choosing not to speak to us? No, he's not choosing not to speak to you at all. He's got no control over it.
He's shut down.
It's as if he's having an epileptic fit. You know, this is what's happening, and then, oh, right, okay. And so, I've used this quite often. You know, I'm not going to allow his brain damage to be criminalised. I'm not going to allow that to happen.
So,
and when you say that out loud, they're like, oh right, yeah, we'll see what you mean. So
And that's the thing, and that's where understanding helps. And this is where that early intervention comes into it, because it helps you change the direction. It doesn't stop things happening.
No.
But it does change the perception of how things go, so you can change that longer term outcome. You can think about other strategies. So there's one of the best interventions. The kid really struggled, had been adopted by a foster family from day one, the same foster family adopted, so it's nothing about neglect or anything like that at all. But the kid had lots of sensory issues, so just simple things like wobble cushions made a difference. They lived on a farm, so when he was stressed, one of their things was go outside and just walk around the farmyard and shout as much as you want. And that was his de-escalation, and he learned to do it. So there are things that you can do. Now, in some situations, if you're living in a tower block in the middle of London, going out and shouting a lot probably is going to get you arrested as well. But
yeah.
but it's, so you have to modify that based on sort of the situation. But it's understanding, and that's what we mean. And my big thing is I've said it a lot, is hashtag change the narrative. I want to change the narrative of this condition, because it is so negative that nobody wants to have anything to do with it. And actually, it doesn't have to be negative at all.
Totally agree.
Yeah, and that leads us on very, very nicely actually to our last question. What would your parting message be for families who've received a diagnosis, and as you just said, we're trying to step away from the negative, and it's not about here's your 50-page book, go and fight for support, and
what's wrong with your 50-page book? It's a lovely 50-page book, I'll have you know.
I'm sure it is. I'm sure it is. But what is what is that final message that you give when they're leaving you, and how, because I know that you do have hope, you do have positive messages for these families.
No, I think it is very much is that actually, if you understand the person, you can change the direction, you can make it a positive outcome, you can actually have a good quality of life with this group. The less damaged they are, the milder version people can go on to have their own families, can have their own lives. It is not the whole negative, everything's going to be disastrous and whatever. I don't know if I should mention names, but Sharon Jackson, I'll mention her. But Sharon, sort of, because she's a support worker, the kids talk about themselves all the time. Andy went off to Ghana with the FIFA. I'm jealous as hell of some of the things that these guys get up to. I'd love to have done that, but when you saw him at the start, there's no way you'd be thinking about that. But good quality family support around the individual, knowing the support that you can have and building on their skill sets lets them have a really good quality of life. That's the thing to bear in mind. It doesn't have to be everything is really bad, everything is really negative, which is what it feels like sometimes when you scan some of the support groups, because people get stuck in the position that you talked about, is that they're in the bad place, and then they need to vent. So they vent, and other people come on who are new and they read it, and it feels really negative. And actually, it's not always negative. It can be awesome.
Panic, doesn't it? It causes panic with a lot of new people, because they think, oh, this is what it's going to be. And the reality is, like any kind, so the online support groups are like any kind of social media. Quite often people, it's either all of the bad bits or all of the you're too busy enjoying the good bits to want to then talk about them.
And you need to have those places, because it's really important that they exist, because people need that place to go. And so don't get me wrong, they're really important, really valuable resources. But if you just hang around on them every so often, and just see what's going on and what people are saying, and that actually it feels sometimes that we need to say, well, actually, my kid had a really good day today. He did this. And I love it when I see the rewards that people come up with, and they say, look what they did. Isn't it awesome? That's what I like. I like the positives, and actually by explaining to somebody what they can and can't do, and then you going away and actually saying, yeah, that's okay. And it changing your narrative as a family, as a whole, because it's not just the individual, it's changing everybody's narrative. It makes the quality of life a lot better, and that's what I'd like to see.
What a brilliant place to end. That's what we all want to see, isn't it? Changing everyone's quality of life, and everyone who's involved in the world of FASD, parents and carers and professionals who work with these children, that we want to change. it can be a happy place for everyone because it is glorious when the right thing is in place. It's euphoric. I experience euphoria sometimes when, and it might be, well, actually, my little girl has started a brand new school, and today she stayed and ate a school dinner at school. Glorious, absolutely triumph of a day. Something as tiny as that, but so I sometimes feel really lucky because the tiny things that a lot of people take for granted as just normal things in their lives, like the kids going to school, the kids eating dinner at school, they're huge to me, and I get to revel in that joy from those little things. So I don't really need the big things to bring me happiness. It's the tiny little things. So I think I definitely focus on that and say it, and I do make myself focus on it, because you can become drenched in fear and the negativity, and it's just it's a pointless road to go down. So I have thoroughly enjoyed listening to you as a parent. Like, you are my go-to person to read, to listen to. So it's been an absolute pleasure that you've joined us.
I'm going grey. I've been doing it too long. Losing my hair.
Yeah. No, Raja, we really, really appreciate you joining us. And taking time out of your Friday night to speak with us and help us share these messages. And you've reinforced everything that we've been talking about. Well, yeah, but thank you again very, very much. We really appreciate it.
You're more than welcome.
And I'm sure everybody will really enjoy hearing you talk about this. And thank you.
We'll talk to you all next time. So thanks very much. Goodbye from us.
Goodbye. Bye.